Good afternoon and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. I'm Peter Johnston and I'm the Vice President for Workforce and Corporate Engagement at the College. I'm delighted to be hosting this discussion today where we're going to introduce the best practice recommendations for staffing and workload in cellular pathology departments. I'm delighted also to introduce today's speakers. The first is Dr. Paul Barrett, who will give us a short presentation. And the second is Professor Adrian Bateman, who's the chair of the Cellular Pathology Specialty Advisory Committee in the college, who will be making some comments. Just before we start the webinar, I just want to tell you that the presentation is approximately 10 minutes long, with about 20 minutes or so for questions and answers thereafter. We're planning operating the Q&A slightly differently from our usual format for these webinars. We're aware that there's a need to support members with the implementation of these best practice recommendations and how we formulate the advice around that. And so we may not address many of the questions, if any, depending what we get today, but instead we plan to invite people to submit their questions through a form that will be available on the Staffing and Workload webpage in the college webpage following the webinar. But of course, we're also delighted to receive any questions on the Q&A button on Zoom today. It's on the bottom of the screen. And if you put a question in there, then we will respond to it, probably in writing after this, taking the various questions and theming them together. So without further ado, I hope that's clear to everybody, and I'd be delighted to hand over now to Dr. Paul Barrett. Paul.
Excellent, thank you. So thank you for that kind introduction, and I was delighted to be part of quite a large group of colleagues who authored the Staffing and Workload for Cellular Pathology Best Practice Recommendation, and the authors are listed here. We're a diverse group from specialists to generalists, special interests in a number of different areas, and from several geographic areas as well. So the aim for me to discuss today is really the historical perspective, how we got to points, certainly how in Durham we managed to introduce a workforce or a workload system, to look at the principles behind any points allocation system, recognizing that all will have some advantages and disadvantages, what's new within the current version, and how we see this progressing with a sort of living document future. So my interest in this was about 2 decades old. I was introduced by Richard Carr, a colleague in dermatopathology, who described his prospective work allocation system in the Journal of Clinical Pathology back in 2006, and after a number of discussions with Richard and colleagues at Warwick, we introduced the system in Durham, and then we shared that more widely with colleagues within the Northeast, and ultimately North Tees published a variant of this system, the Warwick system as it was known as, within the quality improvement document at the time, which seems quite prudent now given the pressure that we will all be under to achieve the 10-day turnaround time. This was achieving a 7-day turnaround time and was published in November 2010. So you can see this is quite an old systems that we're talking about. So going back to the college versions, really the initial version was in 92, which was really only on the number of requests received. Then the second version of the document introduced a degree of complexity, but was only done retrospectively after the diagnosis had been made. So it was only really until 2012 when a prospective complexity measure was introduced or described, as well as a session for quality assurance for giving second opinions, for reading around subject matter to try and gain the best outcome for a particular patient. 2015 saw a minor revision to include ophthalmic specimens, and my involvement was from 2016, when the SAC suggested that we rehash it all and re-review it and really look at it in detail, which we did over a period of time using Gareth Bryson's excellent system that he'd introduced in Glasgow as a basis, and a number of meetings and a number of reviews ultimately ended up in us publishing in 2019 for a fellows review. Although at that point in time, obviously, we had difficulties because there was a global pandemic, and we suffered with trying to get the feedback incorporated, and there was a significant amount of feedback that we did deliberate and discuss. And I think we used then that opportunity to republish a better or an improved version in 2025, which is the one that we are discussing or providing some guidance on today. So what was the aim? The aim was always to provide some form of benchmark, and benchmarking is always problematic, but it was trying to look at balancing the capacity of clinical staff with the demand that was there, not just in terms of volume, but also in a degree of complexity. It was thought that this would be introduced within a time-based individual job plan. It would be based on the relative amount of direct clinical care provided by the individual. It would be based on organ systems, and so each of the systems is described in an appendix, and it would not be excessively granular. It would try and lump things together, not split everything up. So it would try to be all things to all men. It had a number of provisos. It would need to be introduced, or its introduction will be advocated into adequately resourced departments. We recognized that it was an average. So in each sample, a small benefit on a number of cases would then give time to take the additionally complex specimen. This worked by and large, but obviously those ratios may change and may need modification. And it was entirely expected to be a mixed bag without people particularly cherry picking, although it could be introduced for specialist working if people were only practicing in one of the organ-based systems. So interestingly, also from what it isn't, it can't replace terms and conditions. It has no bearing on the other aspects of the job plan, be they supporting professional activities or additional roles. And while it can form a sessional objective, it's not necessarily synonymous with that. So it could be varied week to week, month to month, or even year to year. And so really crucially, it should be introduced with agreement of managers and other colleagues. It shouldn't be mandated by the consultants or by the managers, but it should be negotiated and introduced with a degree of collaboration. So the underpinning principles are to effectively protect patient safety, and this is by avoiding excess workloads rather than trying to cram as much work into a programmed activity, an expectation of an amount of work that could be done in a number of programmed activities, let's say either across a day, a week, or a month, would allow somebody to say, actually, if the demand is too great, I only have this particular amount of capacity, I've worked my work. It would advocate for, or the underpinning principle would be that there would be equitable distribution, and it would be based on the complexity of the samples, not numbers. So everybody would get some cases that were urgent, priority non-urgent, and you would get cases that would be from a range of that particular condition or that particular pathology. And it would try and be something a little bit like a light particle in terms of it would be both real world, but with nothing hidden to it. So we would see an agile system, but it would be very, very much a system that we could utilize. It's intended to be quite generous, but promote efficiency. And so it should be able to accommodate a number of complex situations, as I say, sometimes borrowing from Peter to pay Paul. And ultimately, though, it would encourage a degree of productivity because we would all expect or see a degree of productivity within one of those 4-hour PA sessions. Again, it allows for planning of resource when discussing job planning with managers or issues that are arising out of job planning. It has a rigid outline, but some degree of innate flexibility. And it also takes into account supervision, recognizing that working with a colleague in training can take a little bit longer depending on their expertise and their experience. So the fifth edition remained a prospective system, but added a number of more categories. So it tried to become more discreet at identifying how long certain specimens would take to report. It did introduce the concept of bundling. So rather than have each sub-specimen within a multi-specimen resection, for example, individually pointed, it introduced an idea that that was all one patient encounter, and we would bundle that all together. It was based on optimal conditions, and by design, we had designed 60 minutes to equal 60 points. But a number of audits done, particularly by Gareth Rowland down in South Wales, showed that this was probably difficult to achieve, and a more reasonable number was 50 points per hour. We did limit it to only the microscopic element because while we felt that microscopic elements, there was some individual variation, we would all advocate towards a mean or approach a mean. That wasn't the same for macroscopic specimen dissection. So there was much more variability there. So what we advocated in that circumstance was just to actually time your dissection and utilize that as the amount of activity done in that particular part of a DCC. And we removed the QC session and made it associated with each of the individual specimens, again, because numbers and complexity seem to reflect that as a better distribution. So what did we do in 2025? Well, we expanded the categories further and we tried to revert back to a time equals points, so that these were now categories based upon number of minutes to report a sample. So this led to some redistribution, but it would be it would reduce some of the high numbered, high pointed specimens and increase some of the low, but it wouldn't necessarily overall change the workload of the department. And as I say, effectively 60 points equals an hour. And we did introduce some recognition of introduction into our reports of molecular information. So what does the future hold for this? What is beyond the fifth edition? So I think one of the things we failed to recognize was how much dissection would be undertaken by advanced practitioners, and how that would not necessarily be as efficient as we thought it might be, i.e. If you do both the macro and the micro of a specimen, you're taking time to do both of those. But if your advanced practitioner is doing one part of it and you're only doing the micro part of it, you may need more recognition of time there to look at the imaging or the previous reports, etc. We had limited knowledge about the impact of artificial intelligence, and I think going forward, if a person is using artificial intelligence to enhance their diagnostic acumen or to populate pro forma reports, then that would need to be recognized as well. And of course, there are new specimen types that have occurred since we published the documentation, and they would need to be described. And we would advocate for some degree of local modification as required, to really make this a departmental living document, not a living document for everybody. So I think I'd like to stop there and I think pass back to Adrian maybe to make any comments from an SAC perspective, and then Peter to chair the panel.
Thank you very much indeed, Paul. I think just at this point, it's well worth just saying thank you so much to all the authors for all the work that went into the production of this fifth edition. I know there was a huge amount of effort made to deliver this. I would also like to note gratitude to all the people who reviewed, and there were many people reviewed those documents and provided comments, and also to the fellows who themselves provided their own comments, which all were incorporated into the final review and editing of this document to produce where it's at just now. So just please accept the thanks from the college on behalf of everybody who did that for us, because I think that we all stand to benefit from this update. I think just before I introduce Adrian for comments, the college, as you know, has constructed a workforce strategy, and this fits into that strategy. The strategy itself is a holistic one, which tends to look at not only the person involved, but also the work that people are doing and the context. So the workplace, the resources available, and the environment and the culture within which they work, all of which contribute to people's ability to deliver service. I think it's important that when Paul was talking about the need to negotiate and consider how best to apply these, given, for example, that the college documents show that the very few departments are adequately resourced, and probably only about 5% say they've got enough staff or more than enough staff. Most people are scraping through with a bare minimum, if that, and many have too much work to cope with. So all those things are important in considering how we go forward with that. So having said that, Adrian, I would be interested in hearing what your comments as SAC chair are.
Thank you very much, Peter. So, yes, hello, everybody. Comments as SAC chair. Well, it's interesting. I wasn't actually involved with creating the document, so I could see it in a slightly different way, probably. But I'd like to first of all add my thanks to those of Peter, to Paul, and all his colleagues for all the work that's been done. All the people who have commented on this manuscript. I know it's taken quite a time to produce, but and of course it's evolving. It will always evolve. So. On the other hand, I work in a large hospital that's fully subspecialist. Everyone's doing different subspecialties. Many people doing more than one subspecialty. I can fully see how, as well as protecting patients, of course, saying pathologists aren't reporting excessive numbers of cases and increasing the risk of making an error, for example. It's also hopefully helping to protect us as pathologists and departments, highlighting excess workload where that's the case, helping to support business cases for new jobs going forward, highlighting in departments where jobs are probably most needed as well, and in parallel with that, just generally helping to I suppose enhance the equity, if you like, between different subspecialties. It's always very difficult, will never be perfect, but this, I think, goes a long way to that, to achieving that. It's obviously up to departments how this is used. I mean, I'm sure everyone on this course well used to using the previous versions, and you would have already decided how you use them. I think some people use them in their departments just to monitor the overall workload of the department. Some people will monitor the individual workloads of consultants. Some people like us will use it to actually allocate work as well, which I think works well in our department. Other people don't use that level of granularity, but whatever's done, I think we will have to accept there's an element of sort of broad brush approach here. We can all think of cases, can't we, where we're allocated X number of points for a case and suddenly it's more complex. And we had a case yesterday reporting with a trainee what we thought was going to be a simple duodenal biopsy. It turned out to contain metastatic melanoma, so it'll need checking the history, contacting a clinician, doing immuno and all these things. On the other hand, I'm sure you can think of cases where you've had what looks like a complex biopsy series, and in fact they've all been straightforward. So that will always happen, and if we're not making motor cars on a production line, there's an element of unpredictability, which again, of course, makes life interesting, doesn't it? So we don't want to remove that, of course. I'm sure that people may want to consider altering things if they wish to. The only thing you've got to be a bit careful there, of course, has to be within with the agreement of your department. But I know that people do make minor tweaks, and I'm sure that as time goes on, as Paul alluded to in this last slide, other things will happen. There are always things in clinical medicine which happen to provide us either with less specimens or no specimens. like for me, that would be hepatitis C specimens that we get now, for example, or other much more complex specimens. I don't know, template biopsies of the prostate, which I don't need to do as a GI pathologist. And also, of course, changes in pathological practice, comparing things, for genomics, things like that. Whatever it is, there'll be changes up and down in terms of what we do and workload, and these things will clearly need to evolve. Not to mention new technologies like artificial intelligence. Of course, we don't know how that will affect us yet. So I would commend this document to you and to your departments. We're always interested in receiving feedback because we do need to evolve things. As Paul says, it is a living document. It will never be perfect, but I think it's a jolly good effort to actually try to illustrate to people, particularly outside of our departments, actually, what we do and what takes the time in our departments. So thank you very much to all of those involved, and those are my thoughts.
Thank you very much, Adrian. Just one of the comments that is in the QA just now is about noticing a difference in the way in which specimens have been categorized. Things like that, there will be these typographic things that will have happened because of the document took several iterations to get to where it is. So if you spot them, please just let us know. This is good enough for us. You don't need to do anything else about that because that has logged it with us. So if you do find things like that, just notify the college through the professional guidelines email address, for example, or click on the links in the document, and you'll be able to get through with them. So that's helpful, and that can be corrected quite easily. So thank you for that. I guess the slightly concerning thing coming through in some of the questions is about, there's no time, for example, to negotiate job plans. Well, I'm sorry, but it is a contractual obligation on the employer that we do negotiate job plans. They cannot and should not try and implement job plans that have not been negotiated. Now, the college isn't in a position to give specific advice about terms and conditions, but the consultant contract is quite clear about a number of things, and the college supports that the use of the consultant contract is a valuable way forward. So if this is not for the college, of course, but if you're not able to negotiate with people, then organisations out there, like the British Medical Organisation, British Medical Association, for example, will help you with that if you are a member. So I think there are things here that needs to be said in this context, although, like I say, the college isn't in a position to provide that advice because it is beyond our remit as a charitable organisation and a Royal College. So that's just in passing.
Peter, can I comment there, because there is quite a lot of national work ongoing about what they term service-led job planning, which actually points back at things like the capacity planning that is inherent within the college document that would then articulate, well, this is the amount of demand you have. How much capacity you need is based on the DCCs of your clinical colleagues, and therefore the negotiation can become very much more how do we sustain a service with a job plan that is matching the service needs. So I think we'll see that come to light much more as we transition from the older job planning techniques, the sort of well-described document of a period of activity, a clinic or an operating list, into something that is much more directed by the service. And I think managers would appreciate the kind of advice here about how do you monitor what your service requires in terms of how complex is it? Each department is bespoke in that. Some departments do a lot of very simple work. Some departments do much more complex work in smaller volumes, but possibly need the same number of staff. So I think that job planning update will probably filter through in the next year or so.
Yeah, I think that's very helpful, Paul. Thank you. I think the I was going to say something in the midst of all of that, but it's gone from me. But just while I'm trying to remember that, you talked about some of the benefits, Paul, and I think one of the things, yes, the thing that you were bringing out there is the value of the data that comes from this document, which enables people to then go to employers and say, well, actually, the department needs more people to do this because this is the amount of work we're actually handling, and using a method which is is validated in practice elsewhere. We think that we can justify asking for 1, 2, 3, 10 more consultants, however realistic that is, and be in no doubt that the demands are going to be greater upon us. The the NHS England person who's involved in running pathology services, Rudian Phillips, spoke at a college conference recently and said that the expectation going forward was that pathology departments would report 98% of specimens within 10 working days. Now, that actually can produce a wry smile at the minute, given the average is around 60%. And how do we get from where we are to where we want to be? Of course, there is no answer to that. So the way in which we can use this to benefit is to protect pathologists from demands that are unreasonable. And the value is to say, well, actually, we're already doing what this document suggests. We can do a little bit more if we want to, but really there's a limit to how much we can and should do to produce safe and sound reports, which, let's face it, an awful lot of patient safety depends on the correct diagnosis being given in a timely manner. And that's what we do. And so the value of this is in those, as well as just the allocation of pieces of work at the start of the day. So I think, again, looking at it in the round, we can use the tool for a number of different things and make sure that we do that. We talked about the benefits. Can you see any potential drawbacks, Paul, in the way in which this document can be applied in comparison to what has been there before? I mean, you've talked about some of the contentious issues.
Yeah, I mean, in terms of obviously it needs administration, it needs people to work into assigning a numerical value. It's not as easy as just picking work up from a shelf in a tray or a digital slide. So I think it does need the support of colleagues across disciplines. So often that's done by biomedical scientists or administrative staff to assign those. It does need a bit of understanding at a higher level as well within the trust. It's great if your pathology managers and your pathology people understand the system, but if it's not more widely known, it's difficult to sort of articulate those. But in terms of drawbacks, I think you've covered it really. No system is ever going to be perfect unless we create a number for every single thing. But I think this is good enough. It doesn't need to be perfect. In fact, it's designed not to be, but it's designed to be good enough. And then if local people do things differently all over the country. We can't understand everybody's own personal situation, so it may need a little bit of modification locally. We measure our MDTs as well in points, and again that allows us to not have to have bespoke job plans to include I'm only going to one MDT. We can do different MDTs. We can share MDTs. And we do an element of macro, but again, that's a little bit more challenging because we are different. So I think there are few drawbacks. You can try it and see whether it's right for you if you haven't tried it before. Bits out, but try and keep it under the principle that we've already agreed that significant modification will make it a totally non-college system. So again, and that's that bit with feedback and living document. If everybody feeds back, then we can maybe craft that for the wider audience, and changes will occur. We can't predict everything. So I think there will be newer specimen types, involvement of artificial intelligence, other staff groups reporting, and supporting us, be they SAS doctors or advanced practitioners.
Thank you. I think the issue here is that if we do encounter specimens that aren't on the list, for example, that we get regularly, well, we just tell the college about it, and it'll appear in the next iteration of the document. In the meantime, let us know how you point them, how you work it, what is your system, your process, because it's then becomes a worked example in the living document that we can rely on, and it's not just somebody plucking a figure out the sky and saying, well, this seems reasonable, but we've got people who on a daily basis are using that experience, and we can share that because that is the benefit of the college, and the nature of this document going forward is that we can actually use it as a living document, which means it will be updated without having to be completely revised. And in that way, it gives it a lot more longevity than others, perhaps. So I think that there are a number of questions in here which are about details. And I think that there are some that I don't really want to get into that level of detail in this discussion because we've been really trying to provide an overview. Because if we once start getting into the detail, we will be here until Kingdom Come, trying to get through it all because there are always these detailed questions. So if you do have detailed questions, and there are some online already, please do send them to us, and we'll be able to look at those and respond to them individually. As I said, the point will be to try and group some of these together where they can have themed answers to a number of different points.
Yeah,
So I think, go on,
on
Paul.
that, Peter, I mean, in terms of, that's the three-dimensional puzzle we tried to solve in terms of having the layers of complexity, volume, and how an average person would handle those. So if you significantly change one aspect of it, as Adrian mentioned, multi people working across multiple disciplines will have, well, actually, if that goes up, then this should go. And so we did try and cross-reference it as much as possible, so that if you shook one part of it, you wouldn't necessarily have to tinker other parts of it. But it was very much thought to be an equivalence kind of thing. It grouped things around. Well, okay, it may be slightly different, but it's in the same sort of ballpark.
And I think the other thing is that, in the meantime, about 40% of UK departments are using digital imaging for reporting. Some people tell us that this works very fast and you can do more, whilst other people say it's incredibly slow, and because of the rate in which images appear and don't disappear and things. So, again, we can't really stipulate or advise around that. It is very much a see how you go, and if these systems are beneficial, then you can consider doing it's acceptable to get through more work. And if they're
Absolutely.
opposite,
There was no indication that if you felt that you had covered the work that you would do, and so we did debate about, less experienced newer consultants coming in who may need to be not given a full allocation to start with, but to have a modified and then monitored against that, versus the more experienced colleague who may not want to take part in other activities, but would be happily to crack through and report a number of extra cases. So while 60 points is sort of the average, it's not to say that other people can't say, well, I'm quick and I'll do 70. Similarly, other people may say, well, look, I'm slow. I know I'm slow. So am I okay to just take 50 points? And then the department chooses.
I think that the thing about that is that we must not allow that to be seen as in some way a term of judgment. It is simply an indicator, an average. And I mean, in our own department here, we've quite often reduced the number of specimens for newly appointed consultants while people find their feet. Because it's a big step now, coming from being a a registrar to being a consultant, the step up is more than it used to be many years ago, because many of us had much longer in the training grades before we became consultants. So it's necessary, just as I say, to think about the individual in the context of the work that we're expecting
Yeah,
them to do,
yeah.
and the environment in which they're working.
And monodiscipline, somebody who's only working in one field may become more productive because they don't have that mental overload of switching between ones. So it is really horses for courses, but again, it's crafted around this is a starting point. This is a discussion. This is workable if you want to do it from get-go.
So I think we plan to run this slightly shorter than usual, just because of the number of detailed questions that are coming in, as I say, and that I don't really want to go through that in any great detail. Adrian, have you got any concluding remarks you'd like to make?
Um, well, I think it is useful, as you say, that there will always be specimens that will be encountered, and specimen types or some of the detailed aspects of a specimen that we perhaps haven't included. And I would encourage people to let us know how they deal with that, because people will have to deal with that, and that can be added in the future. And as you say, I'd like to be able to see this as a document that can be aspects of it can be updated without having to wait a long period of time until there's a major rewrite. I think that would be my vision of the way this would work. So it's a sort of reactive document. So I suppose that's my overriding feeling at the moment. That's the way I would like to conclude myself. Thank you.
Thank you. Paul, have you got anything you'd like to say and to finish off?
No, I agree. I think it's one of those things where we need to give it a go, see what it's like, and then if it's not fit for purpose, we can revisit it. But I think if it does need alteration, it will be fairly finessed and a little bit around the edge, but probably would need to actually advocate for better resourcing to the departments, because I think the current environment is financially restricted. If we've got evidence that can say we need one more consultant or two more consultants, that is better than just going, well, finger in the sky, this might be something. So I think it gives you the ability to measure something, even if it's not absolutely always right.
Yep, thank you very much. Well, I think that's all we have time for now, and I would just like to thank Paul and Adrian very much for their expertise, and again for all the work that's gone in behind this, Paul, and your co-authors. And thank you all on the audience online for participating today. The recording of the webinar will be available in due course on the Staffing and Workload webpage on the college website, and there'll be an accompanying form to submit questions if you haven't already done so during the webinar itself. And that will take a few days to tidy to get on screen, and then it will be available to college fellows and people who have registered. Certainly will be available. It'll be easily available to all of you. So thank you all for your attendance. Thank you for your participation, and enjoy the rest of the fine weather while it persists. Thank you very much.